how do you approach a patient who has, say, progressed on their CDK4/6 inhibitor and aromatase inhibitor in the first line setting, and you're looking for their next line of therapy? How do you go about that decision, and what factors come to play?
Yeah, it's such a exciting time because there are so many options, but it's such a challenging time for selecting the right option, right?
Yeah.
And it's become so important that we have sequencing data on our patients, right? So when we enter that second line space and patients are coming off of their CDK4/6 inhibitors, genomically guided therapy is increasingly important, and we have to make sure that we have data on the PI3 kinase pathway, PIK3CA mutations, AKT mutations, PTEN, and then also ESR1 to be able to select the right treatment. So I'm pretty proactive about genomically testing my patients at the onset, so at the time of diagnosis, because I know those PIK3CA mutations are truncal mutations, and that's good data to have for when that second line approaches. But then I tend to do liquid biopsies at the time of progression as well to make sure I have that data. And then really I select my second line based on the genomic data that
Genomically targeted sequencing data. Yeah, I'm so glad that you brought that up because I'm right there with you. I really truly believe that all metastatic breast cancer patients need to have their tumor sequenced, and whether that is liquid biopsy or solid tumor sequencing or both, I'm 100% on board. I think it needs to be done, early and often.
Yep.
Um, and I love that you brought up the difference as far as these PI3 kinase mutations being truncal mutations,
Mm.
because, I think it gets missed a lot when we talk about this, that you can find that PI3 kinase mutation in that primary breast tumor if that's the only sequencing for tissue that you had, or in liquid biopsy. And so you have kind of complementary options there too. If you don't find it in your liquid biopsy,
Right.
you still can go test the solid tumor as well.